I request the panelists to kindly turn on their cameras to get this webinar started. So I think we can get this session started. A good morning and a warm welcome to everybody tuned in today. It is a fresh Monday morning, and we surely need to learn about something just as fresh as this Monday morning. So, welcome everybody. My name is Hiba, and it's my absolute pleasure in welcoming you all to the webinar on advancements in cancer care brought to you by Kauvery Hospitals under the Hindu Wellness Series. Cancer, of course, has been a fear for most people, but with the right care and prevention, it's nothing to worry about. But to give us more details on this topic, we are honored to have with us three experts from our very own Kauvery Hospital. A warm welcome to firstly Dr. A.N. Vaidishwaran, Senior Consultant and Director of Radiation Oncology, Kauvery Hospital, Chennai. A warm welcome to you, sir. We also
Thank
have
you.
Dr. Induja M.V., Consultant Medical Oncologist, Kauvery Hospital, Tirunelveli. A warm welcome to you as well, ma'am. We also have Dr. B. Anis, Consultant Surgical Oncologist, Kauvery Hospital, Trichy. So let the conversations get started. Our first speaker for the day, we have Dr. Vaidishwaran. He is a distinguished radiation oncologist with an illustrious career spanning over 40 years in the field of oncology. He holds an MBBS, MD, and DMRT in radiotherapy and has further enhanced his expertise through international at prestigious institutions such as the Princess Margaret Hospital and Sunnybrook Regional Cancer Center in Toronto, Canada, and the University Hospital Charity in Berlin, Germany. With his vast experience and international exposure in high precision radiation oncology, he is dedicated to providing the state of the art cancer treatment. His commitment to the field, combined with his comprehensive education and proficiency in advanced radiation techniques, establishes him as a trusted and highly respectable figure in radiation oncology. He'll now be talking to us on the advancements in radiation oncology as well as a tour of the hospital. So, a warm welcome to you, sir. The floor is all yours.
Thank you. Thanks for this nice introduction. And uh, good morning to everybody who is in the webinar today. Um, Myself, Dr. Vaidishwaran, is, as she told you, is from the Kauvery Cancer Institute, Alvarpet, Chennai. Now, before I start about it, my talk, I'll just give you a brief introduction of what's happening in cancer and what the updates are going to take place. And this is a hit and run which was done yesterday. We had a run for awareness of cancer on the 2nd of February, well attended by 6,500 people yesterday. Very successful run, which we did for the awareness of cancer. Obviously, you know, February is the day for World Cancer Day, 4th of February. And the theme of this conference, of this World Cancer Day this year, is united in our goals and unique in our needs. So, this is a very important theme which has been designed for 2025. And this theme will, I think, probably give a big boon to cancer management. This theme, I have already thought about it quite some time ago, and I will tell you why so important that this theme is for cancer management. Before starting anything, you have to know something about the global statistics of cancer. If you look at it, India stands the rose color, or probably the breast cancer seems to be very common cancers. Unlike Western countries, you have lung cancers, which are more common. If you take the Indian statistics goes like this: incidence and mortality. The first stands breast, second cervix, lip and oral cavity, ovary, lung, prostate, esophagus, colorectal cancer, stomach, leukemias, lymphomas, liver, larynx, uterine cancer, and brain tumors. This is in the order of incidence and mortality. I think the chart gives you the clear incidence on one side and the mortality on the other side. So these are global call statistics of India, which has been recently through. I am going to highlight some important things of these global call statistics of in India, and I'm going to talk about the advances in this particular area. If you take a statistics, 1 in 9 Indian people are likely to develop cancer. This is a kind of an extrapolation done in 20, and it was 22 was the estimated projection in 25. That's what it looks like. It's a pretty large figure. So to have some updates about this, obviously, updates are very important in any field of not only in oncology, in all aspects of life. And I am going to talk to you about some cancer therapies, or probably what advances are taking place in these ribbons. These ribbons signify, each ribbon signifies a particular cancer, and we'll discuss about these advances only done in these areas, because after time constraint, I can't going out in all cancers. And these updates will is are happening in our hospital in Alvarpet, the Kauvery Cancer Institute. Before I even start the topic, about everybody who has to know something about radiation, a small brief up. A radiation is a high energy X-ray. It is has the same electromagnetic spectrum of light, and it is not visible, and it is painless. You don't feel the pain of radiation. That's very important. There are three things which I want you to highlight about the whole thing, and uh, unless we know about this, we can't move on to the next part, the advances in radiation. So, like taking breast cancer as the first topic, breast is a very complex organ where you have all three modalities coming into the picture. At one side, you see a very low risk cancer, and the other side, you see a very high risk cancer. So, the pendulum oscillating this way and that way. And in the first, you have an ER/PR cancer with a HER2 negative and a triple negative cancer on the other side. So in this side is in the breast cancers are very low risk categories, and this side of the arrow you have high risk categories. So it depends on what type of cancer you're dealing with and what modalities. As far radiation goes, what advances have taken place is the conventional fractionation of radiation. When I talk conventional fractionation, we are talking about 200 centigrade of radiation. That's a dose which is generally given, is given over a period of 5 to 8 weeks. This is what conventional treatment goes. Now, we have moved from the conventional treatment to hypofractionated treatment. When I say hypofractionation, we are talking about a slightly larger dose of radiation, something like 300 centigrade or 400 centigrade, delivered over 3 to 4 weeks. This is kind of a higher dose of radiotherapy. And we have moved from that to an ultra hypofractionated radiotherapy. That means you're delivering a very high dose, something like 500, 600 centigrade over a period of 4 to 5 days. That means it is very high dose radiation over a short time. So the conventional fractionation has replaced to an ultra hypofractionated radiotherapy in breast cancer. And no more is the conventional 5 weeks radiotherapy or the 15 weeks radiotherapy, but we have gone to the 5-day radiotherapy era, where the entire radiation can be completed in a span of 5 days. That's a very important thing which I want to tell you. So this is not just going to be talking, but you show you the proof that before radiation, after the we don't do mastectomy generally for early cancers. We try to do lumpectomy or removal of the breast tumor, and then follow it with radiation. So if you look at it, this is the 5 days after radiation, 1 month after radiation, and 1 year after radiation. If you look at it, the cosmetic outcome, the cure, everything remains the same. So the idea is, if you could finish the radiation in 5 days, it would cost effectively reduce, time is reduced, and also we are looking at a biological different type of treating radiation of the breast. So in breast concern, this has been the recent advances. And this is what we are having from hypofracture. We are the 28% of our patients had conventional treatment. The rest is hypofractionated or ultra hypofractionated radiotherapy. And the right and the left breast, this is what more or less the same. The right and left, 47 and 50% is our statistics. And if you look at the left breast, very important point, if you're treating the left breast, the problem is the heart. So if you want to avoid the heart, if I show you the arrow, that's how the radiation passes through the heart. So if you want to avoid radiation in a free breathing, you may have to do something different for the left breast. For the left breast, what we do is, it is called deep inspiration technology. That means the patient takes a deep breath and the radiation is delivered. And the due process, the heart is totally away from the field of radiation. That's one important point which has been advances today in breast. And the cosmetic outcome in breast has been excellent today as far as breast is concerned. Next comes the uterine cancers. Obviously, uterine cancer, cervical cancers forms a second major problem in India, and external radiation forms a key part of our treatment. And basically, patients have to be immobilized in a thermoplast like this because they don't want patients to be moving during radiation. That's the idea. And you have a laser fixation of the treatment so that the exact precise area is being treated. No more we want such kind of things in the closet, like proctitis and cystitis, which was day old days, where when you're treating, there is a lot of blood in the motion, or probably blood in the stools and blood in the urine. So we don't want such things to happen. To avoid this, if you look at the one end of my right, on the left side, you see a block of radiation going like a slab. The other side, you see the radiation getting shaped. So this concept of treatment today on radiation is intensity modulated radiation therapy. That means you try to intensify the modulation of radiation and trying to deliver the radiation to the particular area of interest, avoiding the rectum and the bladder, which is in front, and the rectum behind. That's the idea of the whole treatment. So that is advancement which has taken place as far as external radiation is concerned. And the second part of the treatment, which is brachytherapy, which is very important in cervical cancers, which is internal radiation. You put in sources inside the uterus or the cervix and the vagina, and deliver a very high dose of radiation to that area. To do that, we have started using MRI based brachytherapy. That means what is the concept is, those days we were using points. We were just putting various points in the pelvis and treating. Today we are trying to draw volume of the treatment, and the residual disease gets a very high dose of radiation with brachytherapy. A word about endometrial carcinoma before I come out of the gynecological malignancy, that today endometrial carcinomas are not only treated with stage but also treated on a molecular basis. So you have various molecular agents which are being done as immunohistochemistry done, and with the molecular basis and the stage, the treatment is carried out. Next major problem in India is head and neck cancers. 30% of all cancers in India are head and neck cancers, and early stages definitely have a single preference of modality. If you have a local regional advanced cancers, you have a combined modality of treatment. So here is a caution. In head and neck cancers, the tongue cancer seems to be a very, very important organ where you can get into trouble with just one single modality. Suppose you have had a surgery done for a tongue, depending on the depth of invasion or the worst patronage. That's the depth of, what do you mean by depth of invasion? This is called depth of invasion. That means you can have a very superficial tumor on the skin, or you can have an ulcerative tumor on the skin. But if you take a superficial tumor, you get the invasion of the tumor in this area seems to be larger compared to an ulcerative tumor. So it is just not the size of the tumor which is very important, but also the depth of invasion and the worst pattern invasion. On this basis, you decide whether post-op radiotherapy is required for the patient, just not by the size of the tumor or by the stage of the cancer. If you take local region advanced cancers, T3 and T4 nodal positive cancers, you can either use surgery followed by adjuvant radiotherapy or a systemic therapy, or you can do definitive chemoradiotherapy. These are options available for treatment. So if you take oral cancers, I would prefer, the preference of choice is surgery. But if you take a hypopharyngeal cancer or a laryngeal cancer, you can, or a nasopharyngeal cancer, you can avoid as much as possible surgery and keep surgery as a salvage and use radiation as and radiation chemotherapy as a primary treatment. When you do that, you're trying to preserve the organ. It's called organ preserving technology today in radiation, and it's a very strong commodity which is required and very, very important for treatment of cancer head and neck. Basically, I think everybody enjoys colors because the visual colors is given only by men, but is the by the human beings. God has given us the eye to see colors, but the rest of the animals or the inmates don't have the power of vision of colors. So we're using these colors. No more is the days which we use these kind of slab of radiotherapy, drawing the entire area of treatment, making the treatment more complicated. But we are trying to paint the radiation dose. If you look at the 3 points, the first one seems to be a block of colors. Here you see the colors being more organized, and in the third one, you see well more organized colors, the red coming to the center and the blue to the periphery. What does it signify? The 3D CRT was the initial treatment in the 90s. We moved to the 20s to an IMRT era, and from the now the present era is to treat all patients with arc therapy or rapid arc therapy to make the treatment faster, quicker, and more well comfortable to the patient. The idea is to do this, you require some IMRT softwares in the computers, and also some hardwares are required. What is the hardware? The machine should have some kind of a moving tungsten on either side, which will make the modulate the intensity of the beam. So it means if you look at the movement going on, you see various shapes of taking place. So the shapes of the beam is altered during the course of radiotherapy. And this is how the arc therapy is treated. And one patient is lying down and the radiation goes like an arc therapy. And what is the idea of the whole thing? Why am I talking all these things? We are trying setting a balance between the tumor control and the normal tissue complications. Very important in radiation because we don't want to be cooking patients or charring patients. That's what people think. அந்த காலத்துல சொல்லுவாங்க கரண்ட் வச்சிருக்குன்னு. No, no, these concepts have changed totally. So we are looking not to have a collateral damage on the normal tissue, and we don't want this avoidance of sticky saliva, sick, and the patient going for dryness in the mouth. How do you do this? We can avoid this. We can avoid even these kind of dermatitis, extensive skin reactions. How do you do it? IMRT rapid arc treatment is a solution for this. You can do parotid sparing. Parotids are two structures on either side, which is used for saliva. The spinal cord is the area where it goes from the medulla, from the back of the brain down to the to down into the body, which carries all the fibers. This has to be protected. You can protect the mandible, which is very important because you can have necrosis of the mandible. You can even protect the constrictor muscles. These are muscles which are used for swallowing. So when you use these kind of sparing technology, patients' complications are reduced to a great extent, and you are able to get a better cure with a better quality of life. And if you look at nasopharynx, if you see the dose painting on the right side, you see various colors from red to blue. So this kind of paintings are possible only when you use high-end technologies like IMRT or rapid art technology. Moving to a next armatorium, lung. Lung it basically falls in the purview of the surgeon or the medical oncologist. Yeah, so radiation oncologist is concerned, what can be done is when you have inoperable patients who are not medically fit, or I don't say inoperable, I would say medically not fit for surgery, early cancers of the lung, you can definitely use a technique called SBRT, stereotactic body radiation. You deliver a very high dose of radiation to the center of the tumor, which you see in here, a deliver of 60 gray in 3 to 5 fractions. In the due process, you really ablate or really char that area of the tumor. So when you're doing that, if you do this kind of technology, you produce less complications to the surrounding lung, taking the constraint all the parameters. We can do this. We have done a couple of patients in this, and we are able to achieve a good control, especially in operable, not fit for surgery. Next, come to the armatorium of prostate cancers. Prostate cancer is one area where generally occurs in elderly people. People don't miss this tumor because they generally land up in an advanced disease. But today, with the initial investigation of PSA, I think more people are coming to me with early prostate cancer. The two things that are important is the PSA and the Gleason score, which is important for the treatment and careful place selection. We have moved from the era of conventional radiotherapy, nearly 74 gray in 37 fractions radiotherapy, to a 60 gray in 20 fractions. That means you're moving from conventional radiotherapy, as I told you, like breast, to a 20 fraction radiotherapy. And today we can deliver even 36.25 in 5 fractions. That means you can deliver a very high dose of 5 fractions of radiotherapy within a short time, making it comfortable for the patient. That is one important. It's like the floodlight and spotlight. The technology which we have used here is what is called triple F technology. If you look at the spotlight, it's the triple F technology. It's a floodlight, it's regular radiation. So how do you do this? We implant some kind of gold seeds into the prostate, and after the putting the gold seed through a transrectal approach, we take pictures, plan the patient, and we start treating the patient using the traditional matching by orthogonal films and also onboard CT imaging. So this helps us to precisely treat the cancer. So very important, accuracy, not precise, accurate and precise. What we are interested in is accuracy and precision in radiation. Where else could I use this triple F technology? If I have a spinal cord metastasis for a breast cancer, just one area where triple F technology can help, and the spinal cord could be completely spared with an SBRT. If you look at it, that red area indicates an area of radiation, and the spinal cord totally away from the field of radiation. One more area which is non-cancerous, where this kind of stereotactic radiation is used, or short course radiation of 3 to 5 days is used, is the acoustic schwannomas or benign tumors. Schwannomas are benign tumors which occur in the this thing causing tinnitus, vertigo, all these symptoms. They can be operated initially, or residual tumors operated with uh, done with radiation, SPRT. Another area where this in advances have taken place is in colorectal cancers. Colorectal cancers are becoming more popular today in India because of the lifestyle changes and the eating habits. So if we don't want to have a colostomy, especially in a low rectal lesion, what we do is total neoadjuvant chemotherapy and radiation. We do chemo and radiation as fast as possible, trying to avoid the surgical procedure, because colostomy nobody likes. So in the early cancers of the rectum, we can even go ahead and treat patients with radiation and chemotherapy, totally avoiding surgery. So my talk should not end without a topic called protons. Protons are one form of radiation. They have a definite uh, role in the field of oncology, but its benefit and cost and does not mismatch. So, in certain places, definitely protons work, especially for pediatric tumors and early tumors where you want to avoid the long dose side effects of the radiation. But in all fields, protons don't work out. So the cost benefit ratio is disproportionate in proton therapy. So, in a nutshell, my area of as I told you, the first theme of today's February 24 theme of UICC is precision, personalization, and prevention. This is what I have been doing for nearly 30 years of my practice. So, in my oncological services in my hospital, you have an integrated OPD department, a daycare chemotherapy unit. We have the state of the art robotic surgery unit, the state of the art RENAC with the triple F technology. We have a stem cell transplant unit doing bone marrow transplant, a pediatric oncology unit, a neuro-oncology, multidisciplinary tumor board, and a preventive oncology. These are the highlights. To take you to 360 degrees tour around the hospital, this is how we have, this is our LINAC, the fourth Davinsky robotic system, fourth generation robotic system. We have the daycare, integrated daycare, freestanding daycare, not attached to the main hospital, where patients can come, have the treatment, go without entering the main hospital, doing all the billing done there itself in a daycare. All patients have a port being fixed before the treatment, especially when you're having breast cancer patients, extensive chemotherapy done. And also, we have the radiation unit, which has a triple of technology, which can be the state of the art treatment with an onboard imaging system. And you have a pediatric oncology unit, and we have a stereotactic frameless navigation based system of doing neurosurgical procedures. And also, you have an advanced robotic microscope and also intraoperative monitoring system during the process of the tumor with the endometrium inside, so that you can visualize the area of the critical vessels and do the surgery as minimal as possible without much complications. Endoscopic skull-based surgeries for pituitary tumors is available in our hospital. We do it on a routine basis. And lastly, we have integrated, that is, 6 eyes see more than two. That means many people can give more information than just one person. Individually taking a decision is not good. If you have a combined decision of the surgeon, medical oncologist, radiation oncologist with the pathologist and the uh, uh, radiologist, we can get a better information and a better care for the patient. And last not least, you should have definitely a system by which you can. Preventive oncology is very important, because not only treatment is important, prevention is also important, because prevention is better than cure. And definitely is a teamwork. And without a teamwork, we can't be successful. Thank you for the patient listening.
Thank you very much, sir, for giving this webinar a great start. Indeed, prevention is better than cure. So your presentation made complete justice to it. Thank you very much for that. Also, a note to the audience, in case you have any questions for our doctors, you can put them up in the Q&A box, and towards the end, we'll have all of our experts answer them for you. So that's about the questions. And our second speaker for the day will be Dr. Induja MV. She is a medical oncologist with specialization training in hemato-oncology, bone marrow transplantation, and pediatric oncology. She's contributed actively to cancer research, presenting at national and international conferences, including ESMO Asia Virtual 2020 in Singapore and RWE 2019 in Chennai. Her expertise covers all aspects of chemotherapy, targeted therapy, and immunotherapy procedures. With a strong clinical background and a passion for patient care, she remains committed to advancing cancer treatment and improving patient outcomes. She'll be talking to us about advancements in medical oncology and chemotherapy. So, warm welcome to you, Doctor. The floor is all yours. You're on mute, Doctor.
Is my screen visible?
Yes, ma'am, we can see it.
Okay. Thank you for the warm introduction. A very good afternoon to all the audience here. So I am going to cover on the recent advances in the medical management of cancer therapy. I will be dealing with the new drugs, newer modality of investigations which I have come across. So my topic will be divided into three categories. Recent advances in diagnostics, recent advances in therapeutics, and recent advances in cancer screening. So first coming on to diagnostics, like the first thing which I'm going to cover is liquid biopsy. Liquid biopsy is nothing but a simple blood test. It is a minimally invasive approach where the blood serves as a substitute for tissue biopsy. As we all know, whenever a patient is having tumor, the tumor cells will be shed into the blood. The cells which are shed into the blood, like circulating tumor cells, cell-free DNA, they are taken up and they are tested for cancer. This is extremely helpful in patients who are not very fit for biopsy procedure, elderly patients, those who are not willing for biopsy, or those patients in whom the biopsy is quite difficult because of the inaccessibility of the site. So this is a simple test where we can diagnose cancer in patients not willing or not suitable for biopsy. So has it replaced tissue biopsy? No. A tissue biopsy is always the gold standard, but in patients, I quoted some reasons in such conditions it can be used. And does a negative biopsy rule out cancer? No, negative biopsy does not rule out cancer because the concordance rate is less. I mean, only 90% we can confidently say the person doesn't have cancer. There's 10% chance that the person has cancer and it is missed out in the biopsy. So the gold standard is always a tissue biopsy. Next comes the important thing which revolutionized cancer care. It's an next generation sequencing. It is a test which is done in both blood and tissue samples. So it is nothing but we all know cancer is caused due to mutations or changes in the genetic makeup of a cell. So this is a method for analyzing those changes. Gene is nothing but a DNA and RNA. So this method can quickly sequence millions of DNA fragments and it will find out the reason why the patient is having a cancer. So this test has now been recommended as a mandatory testing in lung cancer, prostate cancer, ovarian cancer, and cholangiocarcinoma by all the authorities. The ESMO, ASCO, NCCN all recommends NGS as a baseline test for all these cancers. By this, we can find out both driver mutations and target mutations. By driver mutations, I mean the mutations which are driving the cancer, and by target mutations, I mean the mutations which have drugs which can target the cancer causing genes. They are also very helpful in diagnosing hereditary cancers. When we do a NGS on a blood sample of a person who is having a strong family history, we can tell whether he will have cancer or not. What is the propensity? What is the risk of him having cancer? Can we find out using this NGS testing? So this is the sample report, how an NGS testing report will look. So it's a case of stage 4 CA lung adenocarcinoma, and this is the list of genes. What we are seeing is the list of genes which are tested, and we could see that this patient has a ROS1 mutation, fusion positive. So, and this is a targetable mutation also. We have drugs also for this. So this is how we now target cancer. It's not a common chemotherapy for all patients. So, see, molecularly, they have advanced with all these changes into the cancer armamentarium. Now, one size does not fit all is the now. So, this is now the era of precision oncology or personalized medicine. It's the right medicine for the right person at the right time, right patient at the right time. So, let me explain this little more detail with an example. So this is a pictogram representing a group of people with stage 4 lung cancer. They have the same diagnosis and mostly they have the same presentation. So a decade ago, all the patients were treated similarly. They will all receive chemotherapy, and that's the thing we had. With the advent of NGS and other molecular modalities which we have now, we can molecularly and genetically dissect the patients into like we as we see, we know all the patients are unique. We have a smoker who is having a squamous cell carcinoma. NGS is not showing any mutation. We have a female non-smoker who has a EGFR mutation. We have a drug for that. We have anti-EGFR drugs which can excellently work in such subgroup. We also have a non-smoker with ALK fusion. ALK fusion also has targetable drugs so that the patient may not be exposed to chemotherapy. ALK inhibitors will work. We also have a female adenocarcinoma patient where she doesn't have any target. So for such patients, we can give chemo plus immunotherapy. And we also have a patient with a high PD-1. High PD-1 means they are excellently, they will excellently respond to immunotherapy. So for such patients, we can give immunotherapy alone. So as we see, like with the advent of newer techniques like NGS, we have molecularly dissected the patients into different groups. So most oncologists and most of the audience would definitely agree that each patient is unique and each is a unique cancer, and they need to be and they ought to be treated separate differently. So this is now the state of the art treatment which medical oncology has reached. Now coming on to therapeutics. So I would briefly talk about immunotherapy, adoptive cell therapy, targeted therapy, small molecule inhibitors, and white cells. So immunotherapy, this is another hot topic which is in the news for the past 3 to 4 years. It is now being explored in almost all the cancers. So the violet one is the tumor cells. I will briefly explain how immunotherapy works. So the tumor cells are clever enough to escape the immune system of our body. The blue cell is the T cell, which is the main immune system system of our body. So the tumor cells are clever enough that they will cause T cell inactivation, so and escape the immune system and have a proliferative growth. By immunotherapy, we block the ligands and receptors which cause this inactivation, so that this inactivation is nullified and T cells are active against our tumor cells. It is nothing but harnessing our immune system against our tumor tissue. So last year we had a drug hitting the headlines, dostarlimab. It is also an immunotherapy drug. It is a drug used for a small subset of rectal cancer patients where it completely cured disease in 18 cancer patients. So this is one wonder, like when a group of patients where it works, immunotherapy does wonders. The effects will be prolonged, sustained, and the side effects will be less. The side effects of immunotherapy will be different from chemotherapy. We call it as IRAs, immune-related adverse events. They are quite separate thing. And for the patients whom immunotherapy works, it works. It works for a prolonged period of time. Next is adoptive T cell therapy. By this, I mean chimeric antigen receptor T cell therapy, CAR T cell therapy. So mostly it is used in hematological cancers, blood cancers like relapsed leukemias, lymphomas, and also now it is being explored in some solid cancers. The one problem with this CAR T cell therapy is the high cost. We were till last year importing from foreign countries, and was costing in crores. Now we have the indigenous CAR T cell, which is called NextCAR 19, which was uh, developed in collaboration by TMH Mumbai along with IIT Mumbai. So we now have our indigenous CAR T cells, and it is being explored and tried in many centers in India. So a brief outline how CAR T cells work. It's nothing. We collect the blood of the cancer patient. We separate the T cells. We reprogram the T cells with chimeric antigen receptors. Uh, by chimeric antigen receptors, I mean the receptors can go and bind the cancer antigens, the tumor antigens. So then these cells are made to multiply and these are then infused into the patient. These CAR T cells in vivo, when it goes into the patient body, it attacks the cancer cells. This is how exactly CAR T cell work. So in future, we are expecting a more cut down on the cost of this therapy and everyone has access to it. So targeted therapy has been in cancer treatment for the past 2 decades. But what is important is like the molecules keep on coming and more potent molecules with less side effects keep on coming into that thing. So by targeted therapy, I mean like that these drugs try to interfere with the specific molecules which are needed for tumor growth. It will inhibit molecules which cause tumor growth. So it's more like precision therapy. It fights cancer cells with more precision and fewer side effects. So by chemotherapy kills all cells which are rapidly developing. Targeted therapy on the other side will particularly interfere with molecules which are running the cancer. So the side effect profile will be less. So these are some of the common drugs used. Trastuzumab is used in breast cancer, cetuximab in rectal cancer, bevacizumab is used in almost all cancers, and gefitinib, osimertinib are small molecules which are used in lung cancer. Another thing is we have bites are nothing but bispecific T cell engager. This is also a recent development where the 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 drug has two ligands where it will engage T cells on one side and the tumor cell on the other side, making the tumor T cell to kill the tumor cell. This is another one um, recent update. Now, coming on to cancer screening, we frequently see relatives of cancer patients or very anxious people coming to us asking, "Doctor, is there any chance I will be having cancer?" So now this has come with an answer: multi-cancer early detection test, or what we call it as MCDs. So it is nothing but is a combination of genomics and machine learning or artificial intelligence to detect early breast cancer. We have three tests available: Gallery Gray, Easy Check, which is developed by Dakar Labs and it is frequent, it's commonly available in India. Cancer Check, Seek. These are the three tests available. So, are they really useful? Are they like, uh, should we implement them on a population scale? We will see this. So, first thing is they are highly cost, like the cost factor is there. So, from 6,000 to 80,000, the cost varies. And we don't have any data to say how frequent a person should be screened to detect whether he has cancer or not. So if it is done annually, the toxicity of finances, all these things comes into the and all the world data of this is in very nascent stage. We have only small cohorts of people who have been tested with this, and the rates of false positives are high. If a person is falsely found to have this test positive, then the anxiety which he has to face and the invasive procedures he has to go through, all this should always be kept in mind. And the third thing is like if a person is found by this MCEDs, if she is found to or like the signal is showing for breast cancer, we can't conclusively say that she will have breast cancer. Again, she has to go through a screening test of mammogram, all those things. So it cannot replace the single existing screening test. That is one point we have to keep in mind. So for whom can we consider this? For patients who are highly affordable, who have a strong family history or high risk features for cancer, and for cancers which don't have a standard screening test, maybe we can use this too. Thank you for the patient listening. Thank you.
Thank you very much, ma'am, for giving us that wonderful presentation. We will move on to our next speaker. Before that, in case anyone has any questions, you can put them up in the Q&A box, and towards the end, we'll have all of our doctors answer them for you. And last but not least, we have with us Dr. B. Anis, who will address the gathering. He is a distinguished consultant surgical oncologist based in Trichy with comprehensive expertise in the diagnosis and management of solid tumors, including the head and neck cancers, breast cancers, and more. A firm believer in a multidisciplinary approach to cancer care, he collaborates closely with medical and radiation oncologists to develop personalized treatment plans for each patient, integrating the latest advancements in cancer treatment. He's skilled in performing complex cancer surgeries and organ conserving procedures as well. He'll be talking to us about the advancements in surgical oncology. So, over to you, doctor. The floor is all yours. So your voice is not audible.
Thank you for the
Yeah, also your voice is breaking. I think Sir is reconnecting. So maybe in the meanwhile, while he joins back, we can maybe take one question. So I think Dr. Induja and Dr. Vadishwaran can come on the camera and we can maybe take one or two questions while Sir joins back.
Yeah, you able to hear me now?
Yes, sir, well and clear.
I'll share it again. Yeah. Sorry.
Yeah, no issues at all.
Yeah. Is my screen visible?
Yes, sir, well and clear.
Thank you for the kind introduction. I'll be speaking on the recent advances in oncology from surgical perspective. I'll make it very short. Yeah. So conventional cancer surgery 30, 40 years back were focused mainly on radicality of surgery. That is, we were trying to remove the entire organ along with the tumor and the adjacent lymph nodes, trying to cure those patients. But unfortunately, most of these patients had a lot of complications and a few of them lost their lives. And in spite of these radical surgeries, many of the cancers came back. That is, the patient had recurrence. And even those who survived had a very poor quality of life. So the most important reasons for this poor outcome were our knowledge on the biology of the cancer was very limited. We didn't have the sophisticated molecular oncology information that we have today on understanding the biology of these cancers. And the advanced chemotherapy, the targeted therapy, the immunotherapy that Dr. Induja was speaking about was not available. And again, the precise radiation therapy Dr. Vaidishwaran sir was explaining was not also not available. And for complex cancers, the surgical techniques that was employed was in very early stages. So the recent advancements in the cancer surgery can be grouped into these four categories. The first is incorporation of multimodality treatment. Although surgery is one of the most important aspect of cancer treatment, equally important are this medical oncological aspect. That is the advanced chemotherapy, your immunotherapy, your targeted therapies, and also your precise radiation therapy. So when a treatment is given in this multimodality fashion, incorporating all these aspects of cancer care, the overall outcome improves. And the second most important advancement is organ preservation surgery. We no longer remove the entire organ for cancers. In at least in selected patients in selected cancers, we try and remove only the tumor so that the organ is preserved. Hence, thereby the quality of life of the patient is improved. And the third important advancement is minimally invasive surgery. And minimally invasive surgery includes both laparoscopic surgery as well as your robotic surgery. And we no longer make large incision in the abdomen or in the thorax to remove tumors. And by doing these, by making these large incisions, the patient had very high postoperative pain and a very delayed recovery. And by performing these minimally invasive surgeries, the postoperative pain is drastically reduced, and thereby an early recovery is offered to these patients. And the fourth important advancement is your improvement in ultra radical surgeries. Conventionally, certain tumors were considered incurable. That is, suppose a stomach cancer or a colorectal cancer spreads to the peritoneum. Peritoneum is something like a layer that covers your internal organs. It was considered not curable some 10-15 years back. But now with the advancement in surgical technique and better understanding of the biology of these tumors, at least in selected patients, we are able to cure them of those disease. And majority of the patients, we can prolong their life. And also for tumors, like certain tumors which involve the major blood vessels were considered unresectable a decade ago. And again, with the advancement of our surgical techniques, these patients can be safely, the tumor can be resected, and then at least some group of patients can be offered cure. So the first advancement, that is multimodality treatment, starts with good multidisciplinary tumor board-based treatment decisions. So for any patient with cancer, the treatment decision is based on the tumor board discussions by the team of doctors. That includes the surgeons, your medical oncologists, your radiation oncologists, the oncopathologists, as well as the radiologists. And these decisions are based on multiple factors, including the patient-related factors, the disease-related factors, the resource settings, and all these things. And this makes it truly a personalized cancer care. And emphasizing this personalized cancer care, the World Cancer Day and this year has been given the theme United by Unique. And the multidisciplinary treatment not includes only cancer treatment, it also gives strong consideration to other treatment aspects like fertility preservation, especially in young adults with cancers. And we now know in India, especially many of the cancers, especially breast cancers, are commonly seen in younger age groups now. And it is also important to address the rehabilitation programs for these patients for them to join their society as normal individuals. So, organ preservation surgery is most commonly performed for breast cancers. And a few decades ago, for any breast cancers, we were removing the entire breast along with the lymph nodes. This left the patient with a very poor cosmetic outcome. And with the advanced treatment, most of these patients are going to live longer. And now we have realized that it is not necessary to remove the entire breast in all patients. At least in selected patients, especially in early breast cancer patients, we can remove only the tumor alone and then give a good quality of life, and at the same time cure them from cancer as well. And similarly, in renal cell tumors, that is tumor in the kidney, earlier the only treatment was removal of the entire tumor. And these patients had a higher risk of going into chronic renal failure after 15-20 years. And now we have surgical techniques, that is, even in minimally invasive laparoscopic or robotic surgery, we can remove only the tumor and thereby save the rest of the kidney and preserve the renal function. And another site where commonly organ preservation is done is musculoskeletal tumors. And conventionally, 20 years back, for any tumors in the bone or in a large tumor, in the soft tissue tumor, the only treatment was amputation. But now we have surgical expertise where we can remove the tumor along with the normal tissue and fix in the processes and make the patient move. Now, going to minimally invasive surgery. Minimally invasive surgery includes both laparoscopic surgery as well as your robotic surgery. And conventionally, for any patient with the intra-abdominal tumor, say uterine cancer or a stomach cancer, the treatment was to make a big incision in the abdomen and then remove the tumor. So most of these patients will have severe pain in the postoperative period, and they usually recover late, and they get discharged by around 7 days or 10 days. And even after discharge, they are dependent on others for at least the next 1 week or 2 weeks. And then by the time they resume their normal work, it is around 1 to 1.5 months. And similarly, for lung cancer, we make this large thoracotomy incision, which are very, very painful, and the recovery is very late. And now we have laparoscopic surgery, where you make small keyhole incisions and then remove most of these intra-abdominal tumors, and similarly a thoracoscopy through which lung tumors can be removed. And you have this robotic surgery recently, which again helps us perform a precise surgery. So the advantages of minimally invasive surgery, the most important and most important advantage is a very less post-operative pain. So even after a major resection like pancreatic tumor resection, or a stomach cancer resection, or a esophageal cancer resection, most of these patients get mobilized in first day or second day. Their requirement of pain medication is very less. So because they are mobilized early, their bowel function and the lung recovery is very quick. We can remove their urinary tubes very early, so urinary tract infections are very less. And obviously, because the incision is very, very small, it is less than a centimeter or sometimes up to 1 centimeter. The wound infection rates are very less. The hernia rates are very less, and most importantly, they get discharged very early. That is, even after a major cancer surgery, most of the patients go home by 5 days to 7 days, and then they can resume their own work within a week, and within 2 weeks or 3 weeks, they can even go back their normal job. And the fourth advancement is your ultra radical surgery. So conventionally, tumors that spread to peritoneum, that is, it is a layer that covers the internal organs, are considered inoperable. Now, with the advanced surgical technique like peritonectomy and this HIPEC, where we instill chemotherapy after heating it to 40 to 41 degrees intraoperatively into the peritoneal cavity, thereby attacking the cancer cells. So these are some of the advancements that helps us offer curative surgery to patients. And now with the surgical expertise, we can do something called multi-organ resections. That is, remove multiple organs. In this patient, we have removed the right side of the colon. We have removed the uterus and the rectum. The spleen is removed. The gallbladder is removed. The entire peritoneum is removed with the momentum. And after giving intra-peritoneal chemotherapy, these patients now are living longer because of the advancement in the surgical expertise. So the message is multimodality treatment leads to a better outcome. So whenever possible, multimodality treatment should be incorporated into cancer care. And organ preservation surgery is safe in selected patients, especially in breast cancer, renal cancer, and limb salvage surgeries in musculoskeletal tumors. And minimally invasive cancer surgery can be performed in selected patients, especially pelvic cancers, that is colorectal cancers, endometrial cancers, renal cancers, your stomach cancers, and selected patients with hepatobiliary cancers, and selected patients with lung cancers and mediastinal tumors. And ultra radical surgeries, again, in selected patients, can improve outcome, especially multi-organ resections in patients who had cancer spread to peritoneal disease, or patients who had tumor that are involving the major vessels can be safely resected and reconstructed, and at least a small group of patients can be cured, and majority of patients can have a prolonged life. Thank you.
Thank you very much, Doctor, for giving us that presentation. And with that, we will move on to the question answer session. We have about 14 questions as of now. So I request Dr. Vadishwaran to also come on camera. Yes, amazing. So we'll go through the questions. We have limited time, so let's see how many questions we can answer. So our first question goes, how to screen hepatocellular cancer in known case of cirrhosis of liver? So anyone who wishes to take up the question can give us an answer for it.
Yeah, I can take it. So, any patient with cirrhosis of liver are at risk of developing hepatocellular carcinoma, and these patients should have a tumor marker tested, that is AFP, alpha fetoprotein, and along with an ultrasound of the liver, possibly once in 3 to 6 months. And if there is any suspicion, then they should have a biopsy done. So hepatocellular carcinoma has got higher risk in cirrhotic patient, and they have to get screened regularly.
Thank you very much, sir. Our next question goes, does a biomedical scientist have any role to play with cancer treatment? Any thoughts on that?
Yeah,
What do they define
definitely.
what do they define biomedical scientist? Can it be more
Scientist.
slightly elaborate about it? Is it something to do with biomedical engineering people, or is it research? What are they looking at it?
No idea. So they just mentioned only
Yeah,
biomedical.
definitely they'll have role, but may not be in clinical oncology, but in
research?
research settings, definitely there should be some role.
Thank you very much, sir, for your thoughts. Our next question goes, can radiation therapy given for a CA stomach with signet ring cells?
See, radiation in the stomach itself is a big question mark there. Uh, Basically, stomach cancers have to be addressed surgically. One, whether it is a signet or adenocarcinoma, whatever histology is, surgery with staging is the primary modality, plus or minus chemotherapy depending on the post-operative histopathology report. Radiation in a post-operative setup, there's a very minimal role, especially when you have nodal disease and nodal burden. They have incorporated radiation. But as a primary modality, I would recommend radiation to any form of stomach cancer, because the reason is it is very difficult to cure a stomach cancer with radiation alone.
One more
So
indication will be if there is margin
bleeding.
positivity, we
Yeah.
can go for
Yeah. So generally, signet ring cell stomach cancers are considered very aggressive cancers. And as Dr. Vaidiswaran sir said, the high nodal positivity is an indication. Or whenever a proper nodal dissection has not been done, maybe that is an indication. And the positive margin is indication. And sometimes patients in metastatic setting, they bleed. They have severe hematemesis. So in those conditions, as a palliative to control bleeding, maybe we can use radiation. And otherwise, routinely as an adjuvant,
But
it's not given.
Anish, that point I will differ, because today they have been referring here for adenocarcinoma for palliative radiation. The role of radiation as a hemostasis is only in cervical cancer, and in no other place that radiation really plays a great role. What plays a role here is probably hyperfractionated radiotherapy, maybe large fractional radiotherapy for a short time, maybe worthwhile for this thing. But whatever said and done, it's in a stomach, it is very difficult, because in my 40 years experience, I've never seen a stomach cancer getting cured with radiation as a primary treatment. And if you have a recurrence in a stomach, or probably inoperable cancer stomach, whatever said and done, it's no use. It will only a futile exercise, because your dose of radiotherapy has to be so much to deliver to ablate stomach malignancy. This is what my impression is.
Thank you very much for all of your thoughts on the question. Our next question goes, I am a biomedical scientist with a passion for oncology. Will I still be able to work in a hospital, or what are the scopes available for me?
Again, the same question. It's a research area which he has to choose which type of biomedical subject which he wants to do. So today in India, it's a Western world, I think that is possible, because if you look at majority of the Western hospitals, there is always a clinical and a research department going synchronously hand in hand. For example, if you take the Department of Urology, they will be doing urological work in their Department of Urology as far as urology is concerned, the surgeon or probably whatever it is. there is a research team which goes by the side and does research on that particular branch. So that type of scope requires funding, one, and also a lot of financial aid from either by the government or probably by the hospital, which may come in the future. But there are scopes of, not that there is no scope about research. There is a plenty of scope for research in India, but it requires a lot of financial this thing. This is what my impression is today. In majority of the hospitals, we are not able to do research. One of the reasons is very difficult to research unless the funding is given. Unless the funding is there, very difficult to do research from the majority of the hospitals.
Thank you very much, sir, for sharing that answer. Our next question goes, what is the size of tumor for which SBRT can be given in CA lung?
Anyway, between there are two types of radiation which you can plan for lung. Peripheral lesions up to 3 centimeters, even up to 5 centimeters, we can go for 3 to 5 centimeters. You can definitely do SBRT to the lung. It shouldn't be a problem if it's a peripherally placed lesion. It's a centrally placed lesion, then the dose of radiation has to be remodified. Probably if you look at a peripheral lung, 2 centimeters tumor, 3 centimeters tumor could be ablated using gating technology to deliver about something like 60 gray in 3 fractions or 60 gray in 5 fractions could be delivered. But centrally placed tumor, you have to compromise the dose, bringing down the total dose to 40 gray, 5 fractions. Or probably you may use even 8 fractions to deliver the radiation.
Thank you very much, sir. Our next question goes, can I get some more information on blood cancer? Any thoughts on that?
What information exactly they want?
It just says more information on blood cancers. Maybe you can give a little overview or some important
See,
statistics.
broadly, we can divide blood cancers into lymphomas and leukemias. Lymphomas are diseases of the lymph nodes, and leukemias are blood cancers proper. Like blood cancers again can be divided into chronic leukemias and acute leukemias. Chronic leukemias, as the name mentioned, will have a chronic course and it won't be very aggressive. And we have CML, where we use imatinib, the VNET, the magic drug, and we have CLL. All those come under chronic leukemias. Acute leukemias, we again divide into acute myeloid leukemia, acute lymphoid leukemia. So ALL and AML. So ALL is again basically divided into TALL, BALL. So these acute leukemias usually will end bad unless they occur in pediatric population. In pediatric groups, they have a they have a survival rate of about 90% in Western countries, and our data, our Cancer Institute, all those data have around 70% cure rates for acute leukemias in children and up to teenagers, 18 years. When it occurs in adults, it has a poor prognosis, and we stratify it into AML is stratified again into low risk, good risk, intermediate risk, and high risk. Good risk do well, intermediate risk and high risk, we need to do allogenic stem cell transplant, and with that, the cure rates is somewhere around 30 to 50%. So this is about a brief overview.
Thank you, ma'am, for giving that overview. Move on to our next question. Advanced cancer treatments are currently very costly and may not be within the reach of ordinary people. More than 50% of cancers are known to be due to smoking, cigarettes, and consumption of chewing tobacco products. What are your recommendations to stem the rot of the government, allowing poisonous cancer-causing tobacco crop to be cultivated, levy tax to become partners in the killing of smokers?
I think that is there's a big issue which is very controversial and big issue which is difficult to comment. But definitely, I think the government is stepping inside and putting a very clear sign: smoking is injurious to health. Trying to levy taxes more on trying to ban on hookahs. Whatever ban is done and uh, whatever things you try to do in the form of the government side by levying taxes. One important thing that we should understand as public, that we have to refrain from not doing this. See, the idea is uh, you can't impose laws on everything, okay? Or probably you have to change. The people have to change. The mindset have to change. You see, there is advertisement for every movie If you look at every movie, the first few scenes in that movie will be smoking is injurious health, and you see a very bad scene where a surgeon is where you have a surgical place where the whole thing is oozing out. The first scene itself makes me very nauseating or very sick. But after saying that you still smoke, that means you don't have a mindset for doing that. I think it's the attitude of the people should change, and they should look at it differently, and not avoid smoking, especially smoking, and especially smokeless tobacco. This is very important. I think the mindset of the people have to change more than the government imposing. The government is trying the level best to impose things, but that is a big lobby. Tobacco lobby is a big lobby. It's very difficult to curtail it.
100%, sir. Thank you very much for that answer. We move on to our next question. If a patient has both pancreatic and ovarian cancer, can surgery be avoided to rely upon chemo and immunotherapy? Will that be effective?
Both pancreatic cancer and ovarian cancer, surgery is one of the most important treatment modality if you're thinking on cure. Definitely chemotherapy is equally important. But without surgery, aim of cure is not possible. Maybe we can control the disease, but a complete cure may not be possible.
More thing, they should be tested for BRCA gene. BRCA, the combination of pancreas and ovary, it is more common in BRCA carriers. So that genetic testing has to be done. If operable, surgery should be the option. And maybe it can be consolidated with adjuvant chemo or palliative chemo based on the stage of the patient.
Thank you very much, ma'am, for your thoughts on that. Our next question goes, does full brain radiation completely eradicate cancer?
Full brain radiation.
Yes, sir.
What cancer? That's important, because when you say brain radiation, what purpose? For example, in a metastatic disease, the concept is different. Full brain radiation. We do not do whole brain radiation for brain tumors. Let's be very clear about that. Brain tumors are primary brain tumors and secondary brain tumors. Primary brain tumors are probably astrocytomas, medulloblastoma, ependymoma. These are primary brain tumors. Metastatic brain tumors are totally different, a different ballgame. That means a disease is in the breast or probably lung, which has spread to the brain. So that is a different scenario. For primary brain tumors, we do not do whole brain radiation. We remove the primary tumor and radiate the postoperative bed. This is one very clear statement which I'm making. For the patient who is having a metastatic disease, that means a spread from a breast cancer or probably a lung cancer or whatever it is, the primary tumor, and there are multiple lesions in the brain, then you have to adopt whole brain radiation. This is the idea. But if you see a solitary lesion in the brain, and if it's amenable for a surgery, surgery is a good option. If it is not amenable for surgery, stereotactic radiation to the one area of that particular area is the next option. So whole brain radiation is reserved only to a specific sector of tumors, which has to be very clearly defined.
Thank you very much, sir, for that answer. We'll take two more questions before we wrap up. So our next question goes, how to combat antimicrobial resistance in high-risk cancer patients, its approach and treatment, since sometimes the antibiotics don't work at times. So your thoughts on that?
Can be curtailed only through judicial use of antibiotics. Like every hospital should have an antibiotic policy wherein they routinely check the common organisms and their sensitivity pattern and should frame an antibiotic policy based on that. So, and not exposing to higher antibiotics in the first go for any patient with simple fever or anything. So we should have a tier-like system, first line antibiotic, second line, third line, based on the antibiotic sensitivity pattern of that hospital. And the patients also should be more cautious and when they are neutropenic, they should follow specific precautions so that they don't catch any major infection. And it's a major problem in most of the hospitals, like many drug resistant bugs are there. And, I think we have to follow a strict antibiotic policy and de-escalation and escalation of antibiotics based on the culture sensitivity. Everything should be adhered, and there should be a microbiologist actively involved in this in each hospital. That's how we can combat this.
Thank you very much, ma'am. I think our last question is a very optimistic question. So I think all of us can give our thoughts on that. How do I remove my fear of cancer? So I think each doctor can give a few points.
So, cancer fear, I mean, there are three aspects. One is you should adopt preventive habits, that is, have a good lifestyle, should quit tobacco if you are using tobacco, limit alcohol, have a healthy food and lean body weight. This is preventive aspect. And second is your screening. And if you are eligible for screening of cancer, especially women for breast cancer, any woman after 40 years should have a mammogram every year. And for cervix cancer above 21, 23 years, you should have a pap smear with HPV testing. And for colorectal cancer above 45 years, if possible, get a colonoscopy. And if you're a heavy smoker, you can even have a CT test after 55, 60 years. So these are the screening methods. And the third is, unfortunately, screening methods are not available for every cancer. So for all other cancers, you should identify symptoms very early. So early identification of symptoms, any non-healing ulcer in the oral cavity, you should get it checked. Any persistent cough, any persistent voice change, any persistent abdomen discomfort, vomiting, loss of weight, any persistent low hemoglobin, any persistent bleeding per rectum, that is passing stools, all these things has to be thoroughly evaluated. So when you adapt all these three practices and have a good lifestyle, maybe you can no need to have fear on cancer.
Thank you, sir. Dr. Induja, yes.
Like it's not the cancer which we have to fear, it's the delay in diagnosis. So we should be health conscious, a healthy lifestyle. Sarah has explained everything in detail. Like healthy lifestyle, screening, whatever screening modalities are available, we should not hesitate in getting screened. Especially women, we see most of the tumors topping the chart are women cancers, breast, cervix. So vaccination, healthy lifestyle, and that's it. So we should not fear the diagnosis of cancer. It's the delay which we should fear. Almost many cancers which are early detected or in early stage or can be completely cured with the modern treatment modalities. So delay in diagnosis is the thing which we have to fear.
Thank you very much, ma'am. And Dr. Vaidishwaran, your closing thoughts.
Closing remarks is, I think Anish has listed an entire list of things. The word you said, the word, the question was the fear of cancer. It's like asking me the fear of death. Okay. If a man has to die, he has to die. Okay. You can't fear death. Okay. Something like that. Uh, everybody cannot protect themselves inside a shell. Okay. We are exposed to a lot of agents. We are exposed to a various lifestyle society. We can only curb or try to curtail ourselves from the risks of these problems. Beyond that, we can't do anything. What I would suggest is, if you still have the fear, I think the best thing is to talk it out to a counselor, get that thing out, and find out what is that fear that makes you going about it. So, more than this, a counseling will help this, whoever has asked the question. All these things with the counseling and also a good mental meditation will help you to set down your system down so that you don't have the fear of cancer or death in your system. Because any man who is born has to die. Every man who is longer he lives can be exposed to cancer. So let's not fear of cancer, but let's fight against the problem and try to look at it in an optimistic way. So an optimistic approach with a psychologist or probably a counselor will help whoever has asked this question better than trying to run away from the problem.
I think there was a very optimistic ending, like you had mentioned. So big claps to you all for giving us this wonderful webinar, and all of your thoughts were super knowledgeable. So, and with that, this is a wrap to the super knowledgeable webinar. Like I had mentioned, thank you to all the attendees for joining in, and a big thanks to our panelists for sharing your knowledge with us. All those who haven't got your questions answered, you will get them answered via email. So don't worry about that. This was the webinar on advancements in cancer care, brought to you by Kauvery Hospitals under the Hindu Wellness series. Thank you all and have a great, great Monday ahead. Thank you so much.
Thank you.
Thank you so much.
Thank you so much.